name is Bob Moffett. I'm the director for the Center for Health Policy Studies at the Heritage Foundation. And I welcome all of you this morning to a seminar on what is, in fact, one of the key issues of healthcare policy, health policy reform. That is the tax treatment of health insurance. Over the years, going back many years right now, there has been a growing consensus among economists about how to reform the healthcare system. Whatever you think may be done in the area of healthcare reform, assuming that you want to retain a market-based system, if you want to reform the health insurance system in America, you must reform the tax treatment of health insurance. There has been a growing consensus on that over many years, and this panel that you're seeing here this morning is testimony to that simple fact. We have four outstanding presenters this morning. Senator Ron Wyden will be with us very briefly. Senator Robert Bennett is a leader in this effort. He has been a long-time advocate of health care tax reform. Prior to his election in 1992, Senator Bennett earned a distinction in the business world as an entrepreneur for his success as Chief Executive Officer of the Franklin International Institute. Bennett was named Inc. Magazine Entrepreneur of the Year for the Rocky Mountain region. His Washington, D.C. experience includes service as Congressional Chief Liaison at the U.S. Department of Transportation. Senator Wyden, who will be with us shortly, has earned a reputation as a senator seeking bipartisan solutions to very tough issues, including health policy. His bill, the Healthy Americans Act, is the first bipartisan comprehensive health care reform proposal introduced in almost 15 years. And he's arrived. Thank you, Senator. Before Senator Wyden came to Washington as a senator, he was serving 15 years in the House of Representatives. He attended the University of California at Santa Barbara. There he got a basketball scholarship before receiving his bachelor's degree with distinction. He also attended Stanford University. Received his JD degree from the University of Oregon, and he's taught gerontology at several Oregon universities. Our two panelists from the think tank world are Len Nichols, who directs the healthcare policy program at the New America Foundation. Before joining New America, Dr. Nichols was the vice president for the Center for the Study of Health System Change. He was also an associate at the Urban Institute and a senior advisor for health policy at the Office of Management and Budget during the Clinton years, during the Clinton reform efforts. I remember him very well, actually. Dr. Nichols was previously the chair of the economics department at Wellesley College. He received his doctorate in economics from the University of Illinois. Last but not least among our presenters is my boss, Stewart Butler, who's the vice president of the Heritage Foundation Domestic and Economic Policy team. He is a native of Great Britain, a graduate of St. Andrews University in Scotland. In 2002, he spent his semester at Harvard University as a fellow at the Institute of Politics. Currently, he's an adjunct professor at Georgetown University's graduate school. Stewart has been at Heritage a leader among us all over there in healthcare policy reform. He's long argued for a system based on consumer choice and state-led innovation. Most recently, he's been teaming up with Henry Aaron at the Brookings Institution and trying to get bipartisan cooperation to promote state reform through the federal system. Actually, in the House and Senate, legislation based on the Aaron Butler proposals has been introduced in the House and the Senate. But the effort here is a bipartisan effort to reduce the number of the uninsured. Well, ladies and gentlemen, we have an outstanding panel, and we'll begin with Senator Wyden. Yes, you can yield to Senator Bennett. I understand that's what senators do.
Okay. Ron just wants the last word. I point out, I come from an interesting culture in Utah where the Mormon Church is known as the dominant religion. In Washington, protocol says the important person speaks first. In the church, the presiding officer speaks last. So I can go either way. So it puts me in the position of importance, whichever one you do. I salute Senator Wyden for his leadership on this. He's had the courage to attack health care for the first time since we went through the experience of 1994, which, in the words of President Clinton in his State of the Union message in 1995, he said, we almost came to blows fighting over health care. It was not a pretty scene. And the memories come back a little as we're going through this Iraq debate. Senator Reid is threatening to keep us here during the August recess if we don't do certain things. Senator Mitchell kept us here during the August recess in order to get health care done. And contrary to some journalists' memory, the Clinton health care plan was not defeated. It simply died of its own weight. It collapsed on the floor of the Senate without ever having a vote. And when it was over, the Democrats lost control of both the House and the Senate. And I think the health care debate was clearly a major part of that. When that was over and we had taken control on the Republican side in 1995, Bob Dole appointed me chairman of the Republican Health Care Task Force. And the most significant statement that came out of that appointment was when one of my Republican colleagues, discovering that I had that assignment, said, "You're not going to do anything, are you?" Because this was the issue that we had won control over, and obviously we didn't want to wade into it. And the Democrats were exhausted, and they didn't want to wade into it, and we have nibbled around the edges of health care. We have done some fairly significant things. The Casabon-Kennedy bill passed, and then we've done S-chip. But we've never really had the courage to address the fundamental problems behind health care until Senator Wyden, who was not in the Senate when we went through that. He was in the sheltered, quiet precincts of the House. Had the courage to say, let's address health care in a fundamental way. And I'm honored that he asked me to be part of that effort. The fundamental problem, we talk about, you used the phrase market-based system in the introduction. The fundamental problem is that healthcare is structured in a way that frustrates market forces, prevents market forces from working their magic. And what is their magic? What is the magic of market forces? The magic is it drives up quality and down prices as people try to compete for the dollars by saying, come to me for better quality or come to me for lower prices. And market forces can fundamentally change an industry and change a country. If you read Tom Friedman's book, The Lexus and the Olive Tree, he calls it putting on the golden straitjacket. If you do all of the things that a true market economy demands, it's like putting on a straitjacket because it keeps you within the parameters of those forces. But it's the golden straitjacket, you get rich. And the primary problem with healthcare is that the tax laws put the decision-making power in the hands of people who are not the customers of the service. I've been a CEO. I got to choose what kind of a plan my employees would have. But I'm the only one who got to choose that. The employees had no control over the plan we had. And if I picked a plan that happened to be good for my family, it might very well have not been the kind of plan that all of my employees wanted or needed. Now, because you make the separation, tax laws drive you there, and I won't take the time to describe how they got there. That's a World War II relic. But once you understand that the insurance company that wants to put together a plan is pitching me as the customer rather than the individuals who will participate in the plan as the customers, plural, you have a whole series of conflicting incentives. My incentive is to keep the cost as low as possible. My employee's incentive is to get the best deal they can for them, which may not be the kind of thing I choose. They might be willing to spend more money than I'm willing to spend if, in return for the more money, they can get this, that, or the other that I have decided I'm going to leave out because I'm concerned with overall cost control. Now, the jargon terms in the Healthy Americans Act, we're talking about an individual mandate. Everybody has to have some kind of plan. And for those who can't afford it, we structure systems whereby the government can give them the money to go out and buy what they need, rather than dictate the plan that they will have. And people say to me, yeah, but you'll end up with all these uninsured. With an individual mandate, they'll refuse to do it. And we have devices in the bill where we say no, their plan is provided for them, so that when they show up in the emergency room and say, gee, I don't have any insurance, the answer is yes, you do. You didn't know it. You have insurance. This has been created for you. Now, here are your 3 choices, or whatever it might be. You tell us which one you want, and that's where we'll send the bill, because public money has been going to pay the premiums on those plans. And you just tell us which one. It's your money, and we've been putting it there for you. And that's an innovation that, frankly, had not originally occurred to us, that has come from the right. Now, the idea that has come from the left, that we have embraced, is the idea that everybody ought to have a plan. Everybody ought to have some kind of choices. And the choices ought to be similar to the ones we have as government employees. People say, I want the same plan you have in the Senate. My first reaction is, I want the plan I had before I came to the Senate. Because I got to pick that one as the CEO. But fair enough, the same plans that people in Congress have. We have a series of choices. And so there is a degree of the market force present, as I can say, I want this government plan as opposed to that government plan, so that the government doesn't dictate exactly what I have. But the ultimate choice comes when the individual controls the money. If we break the link between the employer and the insurance company and replace it with a link between the individual and the insurance company, a whole series of important things starts to happen. Number one, the people who devise the plans begin to change them to make them more attractive to individuals. And the whole series of market niches begins to emerge. Niches that are papered over when you're formulating plans for large companies. Now, you've got to compete for individuals. HMOs, which medically, frankly, are a good idea. A gatekeeper that checks you out and says you need to go to this specialist rather than that one, that helps you navigate the system, good idea. HMOs have turned into cost containment devices rather than good medical. So, if you're in an HMO and it doesn't meet your needs, you can say to the people that are running that HMO, I'm taking my dollars down the street to a competing HMO. Oh, well, what did we do wrong? Well, you kept me waiting for 4 hours. Your facilities were dirty, your doctor was inattentive, I think your costs are too high, but with transparency I've been able to compare what you charge for this with what the other guy is charging. Oh, as the CEO of that HMO, what am I going to do? I'm going to say, okay, clean up the facilities, get the waiting room reorganized so that people are only there for 15 or 20 minutes. What can we do to match the prices of the folks down the road, which probably means better quality? And the transparency, we are losing market share because people are walking out of our HMO to a competing HMO. Right now, tough. Your employer has picked our HMO. We don't care whether we take care of you or not, as long as the employer is happy with the cost containment we create. You see how market changes, market forces, true market forces, which gives the purchasing power to the person who receives the services, changes everything. So Republicans have decided we're going to have to recognize that the nation demands that everybody have some kind of health coverage, and that means paying for it for the poor in one fashion or another. But the best way to increase quantity and lower costs, Democrats have to recognize that a single-payer system run by the government is not the way to do that. And so, this Republican and this Democrat have reached out, joined arms, and are moving forward, and we're picking up a little momentum. And I will shut up at that point and let the lead sponsor tell you how much momentum that is.
Senator Bennett has said it so well, you do not need a filibuster from me. And first thing I want to make clear is you do not have to be 6'4" or taller to be a sponsor or supporter of health care. This is available for all. And I just couldn't have a better partner than Senator Bennett in this cause. And he is, you may know, a member of the Republican leadership. I think this is a signal, again, of the ideological truce that is at hand with respect to this issue. And of course, we've only been at this health issue for 60 years plus. It goes back, most of you weren't even born during the start of this whole debate. Harry Truman, 1945, 81st Congress. You can almost set your clock by it. I mean, every 10, 12 years, there's an effort to go at it again. And what Senator Bennett has touched on is really the ideological truce that we are right at the cusp of that is key to the breakthrough. Democrats have long felt strongly about coverage. You absolutely must cover everybody to fix health care. Because if you don't, the people who are uninsured shift their bills to people who are insured. In other words, that's the reality of what happens in this country today. It goes on in hospital emergency rooms, it goes on in every neighborhood where an employer covers people, and then there are people who are uninsured. And the ideological truth that Senator Bennett has talked about is a big leap for activists in both political parties. When you talk to a lot of Republicans and you hear the words universal coverage, and Senator Bennett and I have some very funny conversations right away to a lot of Republicans, it makes it out like, oh my goodness, socialized medicine, all-encompassing, government. I'm never going to use those words, universal coverage. Then you talk to a lot of folks who are Democrats, and they have been schooled sort of on the same sort of principle. We ought to have a single payer and have a Medicare will run everything kind of approach. And along I come and say, I think there's a better way to go, and we know something about it because it's what we have. Private choices, alternatives, options, and the like. And I do think that Democrats and Republicans are coalescing around this ideological truth. I think they're also coalescing on a couple of other kinds of key points. We are spending enough money today on American health care. We are not spending it in the right places. And the math is what is really frightening. With 2.3 trillion of us, you divide 300 million into 2.3 trillion, And you could actually go out and hire a doctor for every 7 families in the United States and say, doctor, we're going to pay you $200,000 for this year, and you are going to take care of these 7 families. And every time I bring this up with a medical association, they always say, Ron, where can I go to get my 7 families? Because they like to be doctors again, not bean counters and people walking through bureaucracies. We're spending enough money, folks. We're not spending it in the right places. And Senator Bennett and I feel very strongly that one of the keys to spending it in the right places is to redirect the tax code, redirect these $200 billion that go out through the federal tax code and go out in a way that is both regressive and encourages inefficiency. And we feel strongly that we ought to cut the link between health insurance and employment. Something we came up with in the 40s when there were wage and price controls. Doesn't make a lot of sense for 2007. But I think one of the key parts of this that I'll just wrap up with is that you saw in 1993, and it will sort of ever be thus as we tackle health care. If you're going to reform the system, you've got to be able to respond to why reform works for people who have coverage today. And that, of course, is most people. And in 1993, most of those people who had coverage said, I don't want any part of this because it just looks like I'm going to pay more to get less. So we have come up with a proposal that we believe will work for people who have coverage and offer coverage, employers and employees, with the very first paychecks that go out the door when the Healthy Americans Act was adopted. What we'll do with those very first paychecks for workers is we'll put more dollars in their pocket in order to make the transition. They'll get more choices, more private sector choices, because usually with their employer they get just one. And we will also ensure that their coverage can never be taken away. Once they sign up, they are in the system forever. Everything is essentially adjusted through electronic transfers. If they aren't working, they get a bigger subsidy. If they are working, they get a little smaller subsidy. And we're able to finance this because we are redirecting tax expenditures. We're making administrative savings. This is all documented in the Lewin report. It's on our website, so you can see it. We get tax savings. We get administrative savings. We get savings because we're not sending people to hospital emergency rooms. We get savings because we have more efficient care for the poor. In Oregon, there are more than 30 categories, for example, of Medicaid, where poor people have to try to dive into these boxes in order to get coverage. All that is eliminated. So we're getting better care for poor people at less money. So the state of play in the Congress on health care is essentially this, and I'm going to close with this. The first item coming up this session will come up in the next couple of weeks. It's called the SCHIP, the Children's Health Initiative Program. Our hope is, Senator Bennett and I and a group of others on both sides of the aisle, is that we can keep the peace on this Children's Health Initiative Program. That we can get both parties to say, let's target in on covering children. That it is a moral blot on our nation that so many kids go to bed without coverage. Both political parties ought to come together to cover children. We ought to do it in a cost-effective, targeted way. Both sides have already given in the Senate Finance Committee, Democrats coming down in terms of the total amount of coverage and reducing extra groups of people that might get covered. Republicans have said, we want to work with Democrats. We've got a chance, a real chance, to get bipartisan cooperation on the Children's Health Initiative Program. If we can do that, Senator Bennett and I will be in a position to say, let us now segue, building on this cooperation that comes about through the Children's Health Program, let us now segue into the broader topic of fixing health care. And and let us try to go where no Congress has been able to go for more than 60 years. Now, of course, the popular wisdom is it cannot be done, impossible, nobody is going to be able to get serious about fixing health care. The two of us don't buy that. If you look at the history of solving big problems, it's in this kind of climate where you have divided government, Republican president, Democratic Congress. Both sides are going to have to go to voters in the fall of 2008 and show real results. And my view is it's going to be even more important after what happened in immigration than it was 3 weeks ago before that bill went down. So the two of us are going to put a lot of effort into trying first to get a bipartisan agreement on the children's health program, see if we can build up some confidence and consensus building and bipartisan legislating, then see if we can move right out of that effort into a broader approach to health reform. We're going to have two great presenters, both of whom I know well and read avidly. Len Nichols, we couldn't have had the Healthy Americans legislation without Len Nichols' good counsel and firing off emails to us in the middle of the night with good ideas and nuggets on how to proceed. And Stewart Butler has really been the pioneer in causing a lot of us, going back to my days when I was director of the Great Panthers, thinking about how we ought to be looking at the tax code and private markets. So we're very pleased to have both of you here and look forward to working with both of you. And from my standpoint here in the Senate, I could not have a better partner than Bob Bennett, and this is going to be a rollicking ride over the next few months. Thank you.
Well, you know, it's quite an honor to be on this panel. Usually when I'm with a group this distinguished and smart, they just have me for comic relief, and so I'll try to just be brief because it's kind of hard to be funny about tax reform. But I would begin by echoing Senator Bennett's comments about how we sort of have this crazy system because of the way we structure our current tax treatment of health insurance. And you know, it's often said and joking in health economics classes, if you gave an assignment to a PhD student in economics to design a really stupid set of incentives, the answer would be the American healthcare system. There's no question about that. But it's also true, as Senator Wyden said, you know, we're spending enough money now. The way I would start the pitch here is that tax reform is the key to affordable health system reform because it helps us capture some of the money we're spending stupidly now. And the first big thing we can do with it, of course, is rationalize the subsidy. Today, you may know, our employer-based tax treatment essentially subsidizes the top two-thirds of our income distribution. That is to say, we subsidize Bill Gates. And we subsidize at an increasing rate. So the higher income you make, the more we subsidize you. When you think about trying to enable people to buy health insurance who can't afford it, again, the economists would say that's pretty much the dumbest possible thing you could do. So what this proposal that Senator Wyden and Bennett worked out does is essentially rationalize that and enable us to shift the tax subsidy down to be complete at the low end and phase out at a decreasing rate as you go up the income scale. You still end up subsidizing enough people to actually make it affordable for people, but at the same time we stop the crazy thing of subsidizing Bill Gates. Then if you're going to fix the subsidy, the first question you want to ask is, so what are you going to spend this new subsidy money on? What are you going to spend the current tax exclusion money on? And that's where I think Senator Bennett said it as well as it can ever be said. You want to spend it on a market that works. And Senator Wyden made clear, Democrats want to make sure it works for everybody. So you got to have a market that works for everybody. And that's why we look to something like the FEHBP structure. That is to say, where health plans compete within an existing framework, where rules are clear, people have to have access to the products, and indeed you have to have a market that's going to work for everybody, that's transparent, where the market forces can lead to the incentives that we're talking about on both the insurance delivery side and the delivery system side. If we don't learn to buy smarter, again, as Senator Wyden said, if we don't learn to buy smarter, it's not going to matter what we do about financing, because healthcare costs are growing so much faster than economy-wide productivity, we're not going to be able to afford this as a nation. I'll give you one simple statistic. This is what really motivates me. In 1987, family health insurance policy cost a little over 7% of what a median family income brought home. So a median family income took 7% of it to buy a family policy. Today it's 20%. Now that's precisely because healthcare cost growth has been so much faster than economy-wide productivity and wage growth. It's another way of saying we spend 16% of GDP and we used to spend 6%. But it's much more poignant because it focuses on actual individuals. If we don't learn to buy smarter, we're never going to be able to afford this. And in fact, the unaffordability of health insurance is coming to a middle-class family near you, which is precisely why, while these gentlemen are way ahead of the curve, the wave is coming. There's no question. The momentum is building to address these things. So what are we going to spend on? We're going to spend on a market that works. For markets to work, you have to have mandates to make the adverse selection problem minimize or go away. If you don't have that, you're going to have continued devotion to underwriting and targeted marketing and all the stuff that's, in a sense, a fundamental waste. Mandates make the markets work. That's the great genius of Senator Bennett's observation, that mandates are necessary to make this work because it makes the markets work better. And then you can impose reasonable kinds of transparency rules and indeed focus insurers on managing care and managing delivery systems better and make them our allies and not our enemies as we go forward. And that's how you make markets work. You align incentives for everyone. It's interesting to me if you think about the courage it took to do this. And I want to give the President very high marks here because he put the tax exclusion issue on the table. I mean, it was after Senator Wyden, but he did. And let me just say, every president gets that briefing on why you should abolish the exclusion and turn it into something else, either credit or reduction. I was there when President Clinton got his. And here's the way that basically goes. An earnest young person from Treasury comes over and whips out the slides and explains why we subsidize Bill Gates and we really shouldn't and yada yada. And the president says, okay, let me get this straight. If I do this, it'll be good policy and the wonks will like it. And every CEO and every union leader will hate it. How long did you go to graduate school? I mean, next. The point is, this president had the courage to do it. And these gentlemen had the courage to take that idea and actually make it better by making it attached to a market that will work and subsidies that will work for everybody. Finally, let me say, as Senator Bennett said in the remarks before this thing started, this is our fundamentally most important economic problem. If we don't get healthcare cost growth under control, we're going to be in big trouble. Fundamentally, if you look at why so many employers are, I would say, rattling cages, picking up the phone, probably harassing your colleagues, join this bandwagon, try to get this problem solved. Why? What's different now than in 92, 93? I would submit the importance of international competition has become far more salient. You can't push cost increases forward because price competition from other countries is so intense. Our employers basically bear an economic burden, and this is from work we're going to release fairly soon. My colleague Topher Spiro has worked out some of the details. He's in the back there if you have a question, hard question, ask Topher. But basically we've determined that American employers bear a burden for health care that's roughly at least twice as much as other employers. In most cases, far, far more than that. Only Germany really pays half of what we pay. The French may be an exception, but it's hard to tell the French data. I'll leave that to Michael Moore. I'll just say that every other country on the planet, their employers are facing much less of a burden. Therefore, the goal of this plan and the goal of using the tax reform is to enable us to transition away from excessive dependence on employers and free the individual to be the owner of their policy and make this health system far more efficient and responsive. Thank you very much.
Thank you. Senator Wyden and Senator Bennett are the thinking person's alternative to Michael Moore. Because Michael Moore and actually some members of Congress think of healthcare policy as essentially a blood sport. That basically the idea is to trash the other side, to attack people, to suggest base motives to everybody. Senator Wyden and Senator Bennett, for many, many years, along with unfortunately, a small number of their colleagues have taken a very different approach to put the objective and the goals first and to think about how to work together to achieve those goals. So I'm delighted to be on a panel with both of these members who are an excellent example of what we really do want in members of Congress addressing these difficult issues. And they've taken the lead on this. And what I'd like to do is to try to put these efforts, in a sense, in a broader context and also sort of raise some of the questions that have to be resolved and so on as we think about building on this bipartisan approach and to try to in achieving the goal that we want. I think it's very important when you put it in context to recognize that there has been and is a growing consensus in this country that if you are an American or if you live in the United States, then you should be able to gain access to an adequate level of health services and an adequate level of protection against the cost of health care in this country. That's a growing consensus in this country. We are rich and powerful, and people, whoever they are, think that there's something wrong with a society that can't do that, and we haven't been able to achieve that for all our people. And so that's a broad context in which we're working. Within that broad context, I think it's important to recognize there's an environment of attitudes and values and facts of life. And let me just touch on four very quickly. The first is, I think, a general feeling in America that, yes, people should get access in some way to an adequate level of health coverage, but they have some responsibility in return. This is not a one-way obligation. It's very similar to the debate over welfare, where a critical value was the notion more, yes, we should help people who fall on really hard times, but people who fall on really hard times have an obligation, a responsibility to somehow use that to get back into the mainstream. I think the same holds for health, not just for technical reasons, but for a deep kind of moral sense, that assistance in some way requires people to take action, to take responsibility. I think a second element in this context is that Americans, and certainly if we're going to look at the cost of trying to deal with some of these issues, we have to make assistance to people as efficient and targeted as possible. And that's one of the major reasons why the whole tax treatment of healthcare has to be on the table for discussion, because it does exactly the opposite, and therefore must be addressed. Thirdly, there are issues associated with control in healthcare. Who makes the decisions? One of the things that Michael Moore did, in fact, one nerve he touched among all the Americans is the notion that Americans have that somebody else is making my critical decisions. And that's wrong, and I want to have some control. I want to decide who's going to control. Senator Bennett talked about, as an employer, that he made decisions that really other people should be making. People are very concerned about that. So delinking in some way, or enabling people to get greater control of their healthcare dollars and their choices is critical to reaching the broad objective within the value system that Americans have. And that's a critical part of what this approach tries to do. And then finally, I think in terms of the broad context, it's important to recognize that when we start thinking of all the complex elements of dealing with healthcare and insurance, adverse selection, all of these things, you've got two basic visions. One vision is, let's get the smartest people in Washington, put them maybe in the West Wing of the White House, as Mr. Clinton thought was a good idea, and then figure it all out, and then do it, impose it on everybody else. Another is a much more kind of, really a market view in a sense, I suppose, to say, no, better to try, constantly experiment. Let's try to see what works and what doesn't work, learn from our mistakes, and we will make plenty, and try to work towards getting the details of these things right in that way, rather than trying to do it from Washington. I think all these things are critically important and explain why what Senator Bennett and Wyden is absolutely essential in moving this direction and is compatible with other things that are going on. Because we certainly see two broad movements occurring, I think, in terms of looking at the healthcare area. One movement is the notion of looking at how can we encourage greater experimentation and innovation, particularly in the area of insurance, and trying to figure out the details of how you organize health insurance and health coverage. Senator Boyer, Senator Bingaman have legislated, another two bipartisan group have been put forward legislation in that area, and the same is true in the House. what we're seeing in this legislation is the other piece, looking at the financial side especially, and the subsidy side. And that is absolutely essential and in parallel with this notion of encouraging innovation. And also, as has been said, builds on a growing consensus about examining and trying to fix the terribly perverse subsidy system we have in the tax system today, the unfair way we try to subsidize people. The President has been mentioned, has put forward proposals. There have been proposals in the past. Reed's Heritage has been involved in, so the American Foundation, other senators in the past have put forward proposals, the American Medical Association a few years ago, and so there's been a lot of movement in that direction. And so now we have an opportunity to sort this out, to come together and talk it through and figure out what combination of these approaches dealing with the tax system work best politically and technically to reach the objective that we want. And we must fix that tax. It is the elephant in the room. It is the thing that skews everything in the tax, in the healthcare debate financially. And if we don't fix it, we will not be able to achieve the other things where there's often bipartisan support. That said, let me just say that I think there are some issues that have to be resolved in this, have to be thought through. One is, of course, the nature of the tax reform itself. This proposal correctly starts looking at the tax exclusion and beginning to move towards some kind of deduction and so on, and a more precise kind of approach. I favor going somewhat differently in terms of looking at a tax credit mechanism, which I think is even more efficient and so on. But I think these things can be resolved. I think there are all kinds of ways of combining these things and so on, and I think there's plenty of people who can look at crafting this and do so also within a political context. I think employers now are beginning to realize much more than they've ever done before that the tax exclusion was a Faustian bargain. It seemed to be a great incentive to provide all kinds of benefits. Now they're stuck with it, and they see the kinds of problems associated with it. So I think it's possible to reach agreement on that tax. I think there are a lot of issues associated with what do you try to get people to have with any kind of healthcare system. I am concerned that there's maybe a lot of detail in this legislation that tries to specify with too much precision what people should have and how they should have it. So I favor a much more approach of making very broad objectives, stating the broad goals, and encouraging states to take the lead in looking at this, allowing all kinds of alternative packages within a broad framework of objectives, of goals, of what we really want to try to achieve. I think, thirdly, that we do have to look at exactly what the relationship of the employer is in this whole arrangement. I strongly support the idea of making the tax subsidy not linked to whether or not your employer provides you with coverage or what kind of coverage it is. But I think it is very important to recognize that the place of work is a very useful place, an efficient place to sign up for things and so on. This bill points that out. And I think that that's part of a general trend I think we see in our society of using the place of work as an opportunity to enroll in pension programs, as we're beginning to do, as we've been doing in that regard. And I think that's something we've got to basically shake out and get the right role of the employer. I think putting requirements on employers to pay, we must be aware, whilst it may be an easier transition and may be attractive to people, when employers are told pay for something for your employee, that comes out of the employee's compensation, one way or the other, and let's not be naive about that. So it's important to recognize that. And then finally, in terms of the idea of a mandate, whilst I think personal responsibility is absolutely critical, I think we have to be real careful about the idea right now of putting a mandate on people for several reasons, which I'll end on. One is you do have to consider a mandate for what? One of the big worries about people who are resistant to mandates is that it's very easy then for legislatures and for the US Congress to start specifying in detail what you must have to obey the law. I think that's a worrying aspect of any kind of mandate. I think also it's important to recognize that maybe there are ways of getting very close to the objectives of a mandate, of getting very broad and comprehensive and almost universal coverage by other kinds of approaches, by changes in the tax system itself that will encourage people who right now do not get courage to get. I think ideas like automatic enrollment, saying to people, well, you're in unless you actively decline. There's plenty of evidence to say that a lot of this is lethargy and inertia, and we can get a long way in that. So I would certainly favor, as an alternative, trying to get as close as we can with approaches other than mandates, particularly if that then causes opposition, and we should also try to do that. But all that said, let me just return to what I said at the very beginning, that what we're seeing here is a very, very important development, I think, in the history of healthcare policy reform, of a bipartisan approach to deal with some of these central questions, particularly the tax treatment of healthcare, which so far has not had the kind of broad bipartisan support that is necessary politically to allow a serious discussion to take place, so that people like me and Len can come out of the shadows again and be seen in polite company and actually talk about some of these things, because these senators have indicated that serious members of Congress who are seriously concerned about the goals of healthcare reform are talking about these things. And other people ought to sit up and listen and start actively engaging in the discussion and not just ranting about each other. Thanks so much.
Okay, ladies and gentlemen, now it's your turn. Please direct any questions specifically to any one of the panelists. Yes, John.
Well, I think that the subsidies up to 400% of poverty are fairly high, $82,000. Having said that, can you use it? You have to use it inside the pool, or can you use it anywhere, inside or outside? Is there a level playing field to use this wherever you want? I don't know who to address that.
The subsidies are full up to 100% of poverty. Then there's a partial kind of subsidy between 100 and 400. And as you, I think, almost in your question suggest, if you're making $82,000, you're going to get a very small subsidy. And this is about a transition. Remember, we had 70 years of this system that may have made sense for the 40s, but sure doesn't make sense in 2007. So what we're trying to do is figure out a way, as Stewart was talking about, is how do you make this transition? We made the judgment that you couldn't have people getting sticker shock for the very first paychecks. So that's why we developed that cash out proposal, where people who have coverage get cashed out by their employers, and we have fairly generous subsidies, full to 100%, partial to 400%, and of course, under the legislation, you can buy anything you want besides the basic package. We felt that it was important to start somewhere, and so we started at the middle range of the federal employee benefit package. Insurers can offer that package, or what's called the actuarial equivalent. So there's a lot of flexibility for private insurers, and I think that helps to strike the balance. But there's no question that a key part of this, and what was learned in 1993, and people who had coverage, they've got to see if their first paychecks, how it works for them and their employer. You're not going to be able to trick people into fixing American healthcare. They've got to actually see how it works for them. I would like, while I'm up here, just make one point on Stewart's question about the role of the states, because Senator Bennett and I are trying to encourage state flexibility as well. We've got a broad waiver provision. But here's the story with the states. The states have done really great work, given what little bandwidth they've got to operate. The states cannot touch any of the big drivers in American healthcare. They can't touch the federal tax code, they can't touch Medicare, and they can't touch what is known as the Employee Retirement Income and Security Act, the big program for large employers. And so we're sitting here with most of the legislatures winding down, and virtually every single legislature that tried to take on big reform has found it hard to do at the state level. We've essentially got only one state left to go. That's California. And we're all hoping that we'll get some guidance from that. But I think as we get into this question of state experimentation, and I'm certainly supportive of what Dr. Butler is talking about, I think we've got to say the states deserve a lot of credit for what they're doing with a tiny amount of bandwidth. We've got to have some federal policy changes to make this work, and it starts with the question of the benefit packaging and subsidies that people are going to look at right out of the gate as to how it works for them.
Bob Rosenblatt, freelance writer. I'd like to ask Senator Wyden and Senator Bennett to discuss the political delicacy of it for their colleagues who were running in 2008, and presumably the opponent will say, Senator so-and-so voted to raise taxes by $200 billion and to take away your health plan you enjoy at work. How would you reassure your colleagues who may have to deal with that if they vote for your proposal?
If I were running in 2008 and my opponent said that, I would say, you're not qualified to serve in the United States because you're incapable of reading a piece of legislation and understanding what it really says. That's not what we did at all. The money your employer is currently paying in, quote, benefits, unquote, is money you have earned. The point that was made is exactly right. That's employee money. And you've been conned into believing that's free money, that your employer is somehow creating that money out of thin air. Listen, I've been an employer. If you don't earn enough value for me to cover what's in your W-2 and what's on your benefits, I can't afford you. That's money you have already earned. And all I'm doing is saying that money now is yours for you to control and for you to do whatever you want with. And the way you have characterized what I've done demonstrates that you're a demagogue who doesn't understand.
Bob, the only thing I'd add to that, and I spent really a little over 3 years kind of walking all this through Oregon town hall meetings, trying everything out on people. The first thing I'd say to that person is, let me show you how this bill puts more money in your pocket. If somebody tries to say you're raising taxes, I'd say, no, I'm putting more money in your pocket. You know, the worker who gets a $40,000 wage and his or her employer buys them $12,000 of health care benefits gets compensation by law of $52,000. We've legislated the biggest pay raise in the history of the United States here. We adjust their tax bracket, so there's no tax consequences. We put more dollars in their pocket, giving them more choices and more security. And in the instance I described, if the person takes their $12,000 and can buy an insurance package for $11,500, they can go fishing in Oregon, and have a great vacation out there. It starts with putting more money in their pocket.
Okay. Yes, ma'am.
This question is directed to either Senator Bennett or Wyden, and I was wondering, I know that it's important that through this bill that you mandate employers to increase wages for those who are formally insured through the company policy, but what about the discrepancies that you'll find between older families whose children are going to college and getting into businesses, and so that their insurance would soon be going down, their insurance rates through the company, and then also young families or young couples who are looking to have families, would they be able to somehow benefit from the pay raises when they have kids in the future when this bill is newly enacted?
Well, I'm back to Senator Wyden's comment. We'll take the two comments together. Number one, you're not giving them a pay raise. policies. You're just giving them control of money they're already earning. And number two, if that money is buying them a policy that solves their problems now, it still will. And indeed, when market forces get to work, the prices of those policies will come down. So that if the older couple, they're earning that amount of money now, that money is going to a plan of the employer's choice, and now it's their choice. I don't see that it's creating the hardship that you're describing.
I do think, though, that it's that one of the details to get the grammar right on this is that question about, or that issue that somebody who is older and sicker, if you like, today in the workplace, and they have the same cash income as somebody who's young and healthy, in fact does have sort of hidden extra compensation. I guess that's really what we're saying. And how do you deal with that in terms of this kind of legislation? I do think looking at the value, trying to ascertain the value of what the current employer support for a health plan is not a simple thing, and it has to be kind of thought through. We do something similar with life insurance already in terms of looking at the value of life insurance for tax purposes once it reaches a certain, goes beyond a certain level that an employer has. And that tries to make some adjustments by age and that kind of thing. And I think there are ways of doing that. I think another way is certainly within those businesses that have a contract, a union contract, for example, that may be an area for negotiation. To say, well, let's look at how you would ascertain and measure that value. I think there's all kinds of ways that have to be looked at to be fair, so that people think the end result is fair when they then go out into a different market and start trying to buy something with the amount of that compensation. It's the amount of that compensation people get, which is something that's got to be really kind of thought through. There's a lot of ideas about this.
I would certainly agree with Stewart that you can make this complicated because real life is actually complicated too. But in this case, I would go back to Senator Bennett's comment that fundamentally it's the same compensation you're earning now and you're going to get it. And then what's really relevant, I think, is the relationship in that new compensation has been monetized, so it's all in wages, to the price of the insurance you're trying to buy. There's very little in the bill that would require you to charge that older couple 5 times as much as the younger couple. There's nothing there that would do that. In fact, there's a pretty strong commitment to minimize what the market does now with that situation. And again, you can do that sort of risk or premium variance restriction in this context because you have a mandate and you have a risk pool that is fundamentally far more healthy than the one we have now, because you're going to be bringing in all the people who are not buying now, who are relatively immortal, they think.
Let me add one thing that came out of town meetings, again, for the older people. I had a lot of people who were 55 or 56 come up to me and said, I really like this idea, because I'm just hoping my employer can hold on until I'm 65 and I can get Medicare. And so I'm holding on with my fingernails because each year the employer is reducing coverage because they can't contain the cost. I mean, I say employer-based coverage is melting like a popsicle in August. What you have is less benefits and more costs. So right now, what we give that that older person is a chance for lifetime security. Particularly up until they get Medicare, they will have coverage like their member of Congress, guaranteed until they go on to Medicare, as opposed to what they have with employers, and more choices, because right now they've got really only what the employer gives them, and they would go into an insurance market where there was community rating, which is one of the things that has always hammered older people. They need to go into a larger kind of risk pool to spread cost and risk. So those would be the 3 advantages to the older person that you're talking about. And I would submit that probably the most important thing is the security one, and how desperate they are that they're not going to be able to hold on to their coverage until they get to be 65 and can get Medicare.
Yes, ma'am.
I have a question for Senator Bennett. You mentioned, or you presented the example of the consumer who is dissatisfied with its HMO and perhaps because of an inattentive position or disability, and his option to go down the street to another HMO and take business there. But I didn't hear anyone mention the possibility that that patient might have developed, for instance, a chronic condition or be labeled with a pre-existing condition such that it might screen him out of another option. And could you just discuss, I'm just curious to know how you're handling conditions.
Once an individual has a program, that program stays with the individual regardless of where he goes. And we have legislation now saying that you can't deny somebody for a pre-existing condition. The whole question has to do with the size and nature of risk pools. And the present situation creates an incentive to only insure healthy people. Get the very best risk pool you can get. And once you go to a true universal coverage, that is, there's a universal market here, and the risk pool is no longer artificially determined by where you work, although the workplace can be a very efficient kind of risk pool if it's big enough. The General Motors risk pool makes a lot of sense. The corner cleaner's risk pool as an employee doesn't make any sense at all. And that's why we're talking about association health plans and other kinds of things. But once the insurance company says, you know, we can devise a product, an insurance product, that we can offer to all 300 Americans. You see how you've transformed the risk pool here. And included in that 300 million Americans, there's going to be a lot of people who have pre-existing conditions. Well, because we're offering this so widely, selling it so widely, then we are in a much better position to deal with the pre-existing condition than we are when the risk pool is so small.
We have a legal prohibition on discriminating against people with pre-existing conditions. I mean, part of the whole kind of political alignment is private insurance is going to have a lot of opportunities under this legislation. Some people want to put them out of business. Michael Moore, put them out of business, they shouldn't be out there. We've said you're going to have opportunities for a large market, but it's going to be a different market. There's going to be a version of community rating. There's going to be guaranteed issue. You can't turn anybody down. You can't hammer people for pre-existing conditions. And we have used some visionary people in the private insurance sector. Blue Cross CEO from my area, a fellow named Mark Ganson. I think they're prepared to look at this, and particularly, last point I wanted to touch on is our legislation is not just a financing bill. Healthcare always is largely about financing. It is about a behavior-changing effort as well, both with respect to personal responsibility. We have the first ever incentives under Medicare to change behavior. We say that if a senior under Part B, the outpatient part of the program, lowers their blood pressure or lowers their cholesterol, they get a lower premium. This is something conservatives have cheered for years, the idea of actual incentives, voluntary incentives for changing behavior. So that's been well received, and also liberal people have said we've been interested in seeing this program expanded as well. So the financing always gets a lot of attention. This is about changing behavior, personal responsibility, and particularly the focus on prevention.
Okay, yes ma'am.
3 quick questions, and so as to not hog the microphone, I'll go real quickly. First of all, in the legislation, who is grandfathered in? I mean, like, are military retirees, federal retirees grandfathered in with their current plans?
The program covers about 250 million people. Essentially, it covers everybody but those on Medicare and those in the military. Everybody else is covered.
Okay, so retired military would phase into this?
No.
Oh,
so they get military.
Retired military keep the same stuff there.
Right.
Okay. Second question. I think maybe it's implicit in some of the earlier answers, but one can buy insurance anywhere in the country, or can you only buy insurance that's approved by your state?
Insurance is regulated, of course, by the states. We don't change that, although we make it possible for the states to have an interstate compact. You could have New York, New Jersey, and Connecticut. You could have a Rockies compact, Northwest compact. I think the states have reacted very well to that, as have insurers.
Okay, go to the third question. If SCHIP is successful and you get large numbers of kids covered through SCHIP, doesn't that reduce the pool of low-cost customers for general health insurance? I mean, aren't kids the least expensive to insure, so if they're taken out of the risk pool, doesn't that raise the premiums?
If kids are taken out of the risk pool, does that raise the premiums?
For everybody else. I mean, if the kids are covered under SCHIP,
most children in America, ma'am, get their health care through their parents.
Right.
In a private health care package. So we're still going to cover most kids in America through private coverage that they secure through their parents. And we believe that they will have a better deal as a result of this legislation. Now, with respect to SCHIP, that goes to the question of how public programs for low-income people would be handled under this. We will, depending on how SCHIP eventually comes out, look at it in the context of how we're handling Medicaid. What we have said in our legislation is that we will say that if a state under Medicaid offers a benefit that is not in the Health Care Americans Act for children, that those kids have a legal right for it. But we'll have to see how the Congress ends up with SCHIP to determine what would happen with public programs for low-income people. But today, most children in America get their coverage with their parents through a private plan. We think that holds down their costs.
Okay, we have time for one more question. Sir.
Sorry, Peter Stein with the Health Underwriters.
Hey, could you use the microphone so everybody can hear you? Thank you. Okay.
Sorry, Peter Stein with the Health Underwriters. Senators, with your legislation, I don't know if I saw it in there, but with this sort of brave new world that you envision, with the changing healthcare marketplace, I mean, it will be a shock to a lot of people, as you say, particularly for the 2/3, I guess, of folks who get their insurance through their employer now. Do you envision, with all the competition, and it sounds like it's got a lot of promising aspects, continued role for insurance agents and brokers and professionals to help people navigate the new choices and the existing choices in this program?
Yeah, and as Senator Wyden's made clear, the employer is the logical place for people to get their information and to sign up. But let me share with you an experience that I had as an employer. We had a cafeteria plan where we talked about Flexbox. And we said we're going to put up, this shows how long ago it was, $300 a month for you to spend on benefits in any way you want. And it was a very revealing experience to have the people come in. First person comes in and says, "Are you crazy? I got 5 kids. I want every dime of that in health care. There's no flexibility here at all. I've got to have coverage for my family." Okay, fine, that's what you get. Next person comes in and says, "My husband works at Hill Air Force Base, and we have government health care. I don't need any of this for health care. I want it for daycare. Take care of my kids while I come working here." We say, "Fine, tell us the place where you want it to go for a daycare center." Then the next person comes in and says, "My kids are grown, and my spouse has coverage for our family. Can I put all the $300 in a 401k? Yeah. Then one came in and says, "I want it in life insurance." And our benefit administrator said, "Life insurance is a really bad investment. You should put it someplace else." And they said to me, "You should take life insurance off the table as an option. Do this person a favor." And I said, "No. It's the individual's money, and if they feel for whatever reason that they want to have this money in life insurance," I discovered there's a lot of duplication in coverage. because you have two wage earners and they are in two different employers. And when Ron says taking the money and doing a vacation in Oregon, I'll contest that because they'll get a better vacation in Utah. But the money is the point. The individual should have control of their own money.
What a wonderful...
Can I just add one point on that? Because we talked about the big challenge being transition with people who have employer-based coverage and the like. I don't think that's going to be the biggest transition. I think the biggest transition goes to the point that Senator Bennett made and also Dr. Butler, and that's the role of the individual. I had an experience not long ago in Central Oregon. A young guy came up to me and said he liked me. He said, I don't want to do this. He said, I'm young, I'm healthy, and I could just see I had this golden tan, no body fat, and the like. I could... Thank you. Very good. And so this young fellow said, I just don't want to do this. And I could tell he was a skier. He looked at the mountain and said, hope you're never in an accident. But what happens if you are? Hope it'll never happen to you. He said, I've really thought a lot about that. If I get in a huge, huge accident, I'm going to go out and buy insurance then.
Right. That's what a lot of our agents and brokers get this question all the time.
That's going to be the big challenge.
Right.
And so, United States senators have got to be respectful of their constituents. So I said, gosh, that sort of, kind of isn't the way insurance works. You've got to buy insurance ahead of the accident. And that's how we hold down the cost and we spread all the risk and all the rest. He kind of looked at me and said, that's really cool. Think about it. So that's going to be the huge challenge here, is to get people to look at this in a different way. With the employer part of it, 170 million people, I think we're going to think that through because employers, like Dr. Butler said, are going to be involved in the sign-up period. And Nichols has talked about the same thing. We're going to have that partnership worked out. The challenge is going to be these sort of invincibles. You know, the fastest growing group of uninsured in this country is not the poor. The fastest growing group of uninsured in this country are healthy people who, by and large, have pretty good incomes and have just said, for one reason or another, they don't want to go into these pools, they don't want to have to buy coverage. That's going to be the big challenge. But we're just so grateful to all of you for this program. And our other panel members haven't gotten really fair sway on questions. How about if we give the last word to Dr. Butler and Dr. Nichols?
That's fine with me, yes. Dr. Nichols.
Well, I would just like to echo where Stewart began, and that is it's a pleasure, having toiled in these dark halls for so long, to actually see two senators across party lines willing to work together and try to figure out what's common ground. Because it turns out there's a hell of a lot more common ground on this issue than we were allowed to believe in 93, 94. So I'll end on that.
Stewart?
Amen to that.
Thank you very much, ladies and gentlemen.